Good afternoon, everyone. It's Dr. 𝗥𝗘𝗠𝗦 here. As some of you know, I'm an assistant professor of psychiatry at 𝗥𝗘𝗠𝗦 Clinic, Virginia Tech University. Since even before starting my residency, psychiatry residency, I've been a huge advocate of clozapine, that is an atypical antipsychotic, which is gold standard for treatment-resistant schizophrenia. And with research, it has been proven that by far, it is the most efficacious antipsychotic for treatment-resistant schizophrenia and schizoaffective disorder. Uh, Recently, there was an FDA meeting in regards to future of the REMS, that is registry, of which every patient has to be registered with in order to prescribe clozapine, because of course, several side effects. Today, I have a very special guest, Miss Rachel Streiff. She is a clozapine activist, and she was actually there to testify at that FDA hearing. We'll talk a little bit about her journey. How did she become a clozapine activist? What has she and other people in the same boat have done? And what happened at the hearing? And after the not the verdict, after the FDA voted, what is future for clozapine and the patients of clozapine? Without further ado, I would request Ms. Tariff to go ahead and introduce herself.
Hi, thank you, and thank you for having me, Dr. Khan. So again, Rachel Streiff. I'm logging on from Arizona, and I first came in contact with clozapine while researching antipsychotics for a family member who got sick. And I remember going to an appointment with the psychiatrist, and I asked about clozapine, and the response was, "Oh, that's a very dangerous drug. We only do that as a very last resort." And I have since learned that neither of those things are true. Clozapine is actually technically the safest antipsychotic. And I'm actually wearing a shirt that says clozapine is the safest antipsychotic in the world.
That is such a beautiful message.
Yes. And that, of course, is not based on necessarily the immediate management of clozapine's adverse effects. That's based on multiple large-scale meta-analyses showing that individuals taking clozapine live even a decade longer than those taking other medications. And there's a lot of reasons for that, but it does include the active effects of the medication itself. So I finally was able to locate a program in Arizona, in Prescott, Arizona, with Dr. Terry Vaughn that does clozapine. And my family member had a great experience with the medication, went on to make a complete recovery, and has since, endeavored to a career, graduated from college, all of those things. So also in that process, I am legal guardian of a young woman who is 31 years old, and she is on clozapine. And the process of being her guardian and getting her treatment and services has been eye-opening. There was a point that was a pretty significant point in my journey in clozapine advocacy. She was in the hospital. She's someone who kind of makes frequent trips to the hospital. And every single admission, they were interrupting her clozapine treatment. They would, as kind of a matter of routine, anyone admitting on clozapine they weren't keeping it in their formularies. None of the hospitals carried this in town. They would interrupt it. They would special order it. They would require another blood test before giving her clozapine. And one of those instances of her being admitted to a hospital, she effectively lost the consent to participate in a blood test, would be how I would describe it. So she began refusing the blood test, and I drafted a legal document. I said, please, as her guardian, I accept all liability and risk. Please just give her medication without a blood test. And they came back and they said, well, we can't do that. But if you would like to order as her guardian that we restrain her for a blood draw, we're happy to do that. So that was when I realized something's horribly wrong. We would never treat a cancer patient that way. Mm-hmm. She was 11 months into clozapine treatment at that time. So I didn't order a restraint. We had to let her go off the medication. And when we got her back on clozapine a month later, she had to start all over with weekly blood tests.
Of course.
Yeah. And what was most disturbing about that was that a room full of professionals more educated than I am thought this situation was okay. And it's just a violation of anyone's disabled person's right to treatment. So that made me quite angry. And then sort of around the same time, a young woman named 𝗙𝗍 in Michigan went to a NAMI event, and she was also going through some very frustrating things with her loved one related to clozapine. And she started speaking out in a significant way. And that's when individuals in industry and in the advocacy realm started referring to us as those angry moms. And we didn't pick that name, but eventually that name just picked us. And we finally made a website out of it, theangrymoms.com. And that has since grown into an organization of thousands of people who are regularly having issues getting clozapine in the first place, having a continuum of care with the REMS, frequently interrupting treatment, and just general barriers and discrimination and stigma for everything that has to do with clozapine treatment. So that's how it all started.
Well, Rachel, I really appreciate you sharing. And as a physician, I have seen multiple instances. I used to call clozapine as the usual suspect, if you remember the movie. Yes. So what happens is whenever there's a patient admitted to any medical specialty, whether it's inpatient medicine, general medicine, internal medicine, nephrology, even neurology, and that patient is on clozapine, the first thing they suspect is, oh, it must be clozapine that is causing it. Right. And the first thing they do is stop it. So that has been something, and I was RFM, the resident fellow member of North Dakota Psychiatric Society, where I did my training, and I presented in their local meetings. So the presentation of the topic was barriers to clozapine. And what I used is, I am a huge Marvel fan. So there was a picture of Iron Man that the patients and their relatives consider clozapine as that. And then there was a picture of Thanos, the villain, and the medical provider considered clozapine as that. So from our standpoint, I think one of the biggest thing, of course, REMS is one of the biggest barriers.
Yes.
But the other thing is that the providers are scared. I mean, I'll be honest. They just feel, even psychiatrists, some of them, just feel that oh, wow, how can I start it? And then what happens is, because 4 year of residency, they don't get much exposure to it. They don't see patients who are on it. And then after residency, when they have to start it, it becomes so difficult for them. And it's not only for clozapine, it's also for other psychiatric medications, which we don't no longer use that commonly, like lithium. So I think, and we have advocated for clozapine clinics, because if you have a clozapine clinic, then you have your residents get exposure to it, and that actually helps. There's so much research on it. Dr. Singh, my ex-chief resident at UND, with Dr. Rorik, who was our associate program director, they actually did a survey and they sent it to all the psychiatry residents, and their results was, it was surprising, because they were actually not comfortable prescribing it because they were not seeing enough people. And then the administrative barrier due to the REMS, and interestingly, the neutrophil count, the agranulocytosis, it all started with that study in Finland, which some people still feel that that was not a very good study. Some
It
people
was.
also feel that in the soil of that area in Finland, there was something potentially that was causing the neutrophils to drop.
Mhm.
And the other thing is, I'll tell you a quick fact. The what supposed to happen is that anyone who's diagnosed with treatment-resistant schizophrenia should be started on clozapine right away. Now, what is treatment-resistant schizophrenia by definition? Two antipsychotic failures, adequate dose, adequate duration, and that one of them has to be atypical. Now, the mean time from someone getting that two antipsychotic failure and initiation of clozapine, I think the last I checked in US, it's more than 10 years. Just imagine. And in other countries, I I may not be entirely correct about, but I think in New Zealand, Canada, some European countries, it's way less. So that is something that ignited my interest, and I have tried to advocate, of course, wherever I can. I was not actively part of any advocacy group. I was not actively part of any even American Psych Association group, but I tried to do as much as I can. So again, thanks a lot for sharing. So I will
Mhm.
ask you a few things.
Yes.
There's someone we know as a godfather of clozapine.
Yes.
Can you tell us a little bit about him and how has been his role in all of this?
Yeah. So a couple years ago, I got a phone call from a famous man, Dr. Gil Honigfeld, and I knew the name because I'd been researching clozapine at that point for a couple years, and his name was on everything. Everything clozapine. You hear about Dr. Gil Honigfeld. So he was responsible for bringing clozapine to U.S. markets in 1989, the clinical trials that resulted in clozapine's approval.
Mhm.
He developed the blood testing scheme to be able to bring that drug to us with the weekly blood tests initially. And he was the clozapine champion for decades. He fought to get that medication along with several others available for U.S. patients. He has since come out of retirement to end the clozapine REMS. So I got a phone call from him, and I've been working with him back and forth on whatever we can get accomplished to make this terrible FDA clunky surveillance platform just go away. There's another organization called Schizophrenia and Psychosis Action Alliance, who was also very pivotal in getting that joint committee hearing on November 19th of this year in front of the FDA. Also, with the help of U.S. Representative Brad Sherman from California, who
Absolutely.
championed some efforts to get this in front of the FDA commissioner.
Mhm.
So we've been working with Gil on probably the biggest thing that he helped us with is our petition to end the REMS and modify the clozapine product label. If you go to change.org
Mhm.
/ end the clozapine REMS, you see the result of our research work together and a really great explanation of all the research toward clozapine, neutropenia, everything you'd want to know. Why clozapine is the safest
Mhm.
medication or safest antipsychotic medication in the world. Why the REMS is causing far more harm than it is
Mhm.
helping patients.
That's impressive.
Yeah.
I would mention again one thing. As we all know that clozapine, one of the more common side effects is constipation, and it
Yep.
can be that bad that it can actually lead to intestinal obstruction, sometimes requiring surgery. I would tell you that I have had discussion with some patients and their relatives. So there was one particular person who developed constipation, led to obstruction, and actually had a bowel surgery.
Mm-hmm.
Even after that, he was adamant he wanted to be on clozapine. So were the relatives, and they were on clozapine. So
Mm-hmm.
it says a lot. It says a lot that people whose symptoms are completely out of control, they cannot function day to day, and you put them on clozapine. If it works. Of course, I'm not saying that it's 100%. Again, efficacy is still 50-60%, which is far more than any other antipsychotic in the world. But for people, for those who it works, it's a magic drug. It's a
It's a
miracle drug.
miracle.
Absolutely. I would request you to tell us a little bit about, of course, the hearing. What
Mhm.
was that about? What made the hearing possible? What happened there?
Yeah.
And we'll go from there then.
Mhm. So, as I said, what made the hearing possible was a lot of pressure from our group and the Schizophrenia and Psychosis Action Alliance, really partnering with the APA, with NAMI, with various pharmacy groups, and Representative Brad Sherman in pressuring the FDA to put this committee hearing together. We were very excited when this was announced. And we realized that this would be our chance to tell our story. And we put that petition together that I mentioned to you, and we turned that in as our formal public docket comment from the angry moms with 4,000 signatures.
Wow.
And then there was a team of us that raised money to bring poor, struggling mothers to Maryland to tell their 3-minute testimony about their experience with the Clozapine REMS. We also had 4 or 5 patients who are on Clozapine, individuals that rely on Clozapine, that shared their experience with Clozapine as far as what was the impact when it has been interrupted by the Clozapine REMS, and what it's like to live with a rigid blood testing schedule and the stigma surrounding this medication and difficulty accessing services. So we had very powerful testimonies. I believe this is what won the day. This is why the panel voted 14-1 to end the Clozapine REMS. The one dissenter even qualified his vote that he still wanted to see significant changes in the REMS, that it would be limited in time duration, and that it would be more streamlined. So this was a win for Clozapine patients and their families.
Well, that's so impressive.
If you go to the FDA's website and you can Google FDA committee hearing Clozapine REMS, you'll get right to it. You can see that there's a link to the recorded website, the recorded hearing. The entire 8-hour day is recorded, but if you advance to 5 hours and 40 minutes, that is the start of the open public testimony, and you can hear from the families and you can hear some examples. The other thing that has been very visible for our group is that back in April, we became so frustrated that nothing was happening that we started publishing negligence of the week emails. We have since April been taking highlights from the complaints coming into our group from our website and our social media channels, and we've been publishing them every week, the handful of the worst cases. Just yesterday, our negligence of the week email featured a man in Massachusetts that the REMS interrupted his Clozapine for 6 days in a group home, and he ended up in an involuntary hospitalization because of that. So these problems with the current system, it's not even necessarily the REMS program or the pharmacies or the labs, or it's the synergistic, flawless execution of all of the parts and pieces needed for the Clozapine to make it into the patient's hands is completely flawed.
Absolutely.
It's not possible to be sustained.
Absolutely. So now the FDA voted for, what do we do from there? When do we expect? What will happen? What has happened now, and what would happen in future?
Yeah. So these were FDA advisory committees. And I'm told that 80% of the time, the FDA goes with advisory committee recommendations. Now, there have been many recommendations to go to the FDA for the last 35 years, and they have not acted significantly on any of those. So although the FDA leaders that were at the hearing assured us that they were moved by our testimonies and that they would take some action based on that, I will believe it when I see it, and I don't know what that is. When other REMS modifications have occurred for other medications, those are things that normally take 6 to 9 months. And we don't know what they will do. There's a couple possibilities. They could decide to just end the program. They could convert the program to more of a registry or education program, or anything really in between. It's out of our hands at this point, although we plan to continue significant advocacy towards, if nothing else, stop blocking these refills and start allowing patients to have emergency doses and things like that.
Okay, so basically the advisory committee voted 14-1 in the favor of stopping it.
Yes.
And then now we are waiting for FDA to make a final determination.
That's right.
Which then would be followed by all pharmacies and the clinics and hospitals.
Yeah. What concerns me is that every time the FDA has touched the Clozapine REMS, they have messed it up. When they first rolled out the REMS in 2015, it was a disaster. When they modified the REMS in 2021, it was a complete disaster. There's any number of unintended consequences that could happen if they just decide to end the program abruptly. This needs a really big, important approach. There's a couple things that if I have an audience with psychiatric providers who are thinking about clozapine or maybe not so experienced with it, is that clozapine does not cause mild or moderate neutropenia. Clozapine causes for about 1 in 250 patients a catastrophic drop in neutrophils down to nearly zero, where neutrophil production is completely arrested in the bone marrow. It's a very dangerous condition. And we do need to be aware of it.
Absolutely.
There are some really important innovations surrounding this that we need to, as a community, push for. The first one is something called myogenes. There's a genetic test coming out of the UK, Dr. David Taylor, and it predicts the risk of developing clozapine-induced agranulocytosis.
Wow, that is impressive.
Based on the activity of 3 human leukocyte antigen genes. Wow. So this test will tell you if you have a 0.3% chance of developing this problem or a 14% chance of developing this problem, right? So, or what your general risk is. It's not a perfect test, but it's some markers that have been obviously linked to this condition. So if, for example, my child had a risk of 14%, I would get a finger stick ANC device and I would test them every day, right? Yep. So some populations, this testing is vital, probably even more frequently than what we are doing today. Other populations, not so much. Certainly patients who've been on clozapine for the first 6 months, the risk is similar to other medications, and we should be really relaxing the guidelines after that point. So, we are pushing for all patients should have access to finger stick technology, just the same way that diabetics have access to glucose meters.
Rachel, that is very important. I mean, I know it is very expensive. Again, with the insurance coverage,
it's not that expensive, but
so that's an assumption that it is expensive, and that's why the POC ANC monitoring, they have not been able to do it. I think they started at some places. That's
Yeah,
another thing which is very important, that if we can do it for diabetes, why can't we do it for clozapine?
exactly.
That is a life-saving medication as well.
Yeah. And I've had my own device for my own family member for 3 or 4 years now at home. And we do have clinics that are bringing these point of care devices in as well. So this technology with the genetic testing, there is also a finger stick serum level clozapine test being worked on.
Wow.
Uh, there's also some pretty exciting delivery systems for clozapine. There is a nasal clozapine in the works, and there is also through also Dr. David Taylor, a clozapine implant in the
Wow.
works.
That would be like a long-acting kind of a stuff.
So I don't know about the benefit of the intranasal clozapine is that there's more appears to be more going into the brain and less into the body.
Okay.
So it might have less side effects.
Yes. And the implant would be like a
And
long-acting injectable.
yes, the implant would be more of a long-acting sustained delivery system.
Wow.
The molecule itself is not suitable for a long-acting
Hmm.
injection,
Hmm.
although there is a daily clozapine injection in Europe in use that's used in acute settings, and it has a very high rate of conversion to patients taking the oral form. So
Wow.
there's a lot of innovation
Mhm.
happening with clozapine in including what will be ending some of these restrictions.
Absolutely.
And the most exciting thing after that vote on the 19th is how other countries are reaching out to me, to
Wow.
mothers. I mean, for the first time,
Mhm.
I think caregivers in this space have been heard in a
Mhm.
significant way.
No, absolutely. And I want to thank you from not only on my behalf, but I think on the behalf of all the psychiatrists that I know that have been so frustrated by this, because it's I have lost count the times I would want to start clozapine on. I do both inpatient and outpatient, and
Yeah.
then there is no way the patient who would take them to the lab, who would arrange that, no resources, and countless times they are on 2, 3 antipsychotic, 2, 3 mood stabilizers. And what they don't understand is the amount of money that is being spent on those things, and then they have to be hospitalized, ER visits, that supersedes all of it.
Yes.
I feel that I shouldn't say that, but I have to, that it's the lack of vision, and it's the fear. So it's the fear and the lack of vision that due to that it still persists. Well, I hope that the FDA agrees to what the advisory committee has sent, and
I hope
either
so.
they end it or not end it, modify it in a way that the baseline is what you would want, what I would want as a provider is that patient continues to get uninterrupted supply. There should be check marks, there should be check and balance. That, of course, we know that the risk is very high if it happens, but then we have to see that it's whether it's first 6 months, next 6 months, and making sure that patients are able to receive it with that gene site testing, maybe gene testing, or maybe that point of care
Yeah,
behavior.
Myogenes is the
Myogene.
only company that has the neutropenia, and it also detects benign neutropenia.
Yeah.
Yeah,
Awesome. Well,
yeah,
Rachel, I would again like to thank you so much. And
yeah.
I want to say that I want to request that it shouldn't be our last podcast. We should
No,
all also invite the godfather of clozapine.
yep.
Uh,
I'm sure he'll do this.
Yeah, and we should continue to raise our voice. And I again want to thank you for raising this important topic in front of not only FDA, not only the congressional leadership, but in front of all the world.
Yes. Thank you,
Thank
and
you,
thank
and
you
have
for
a good rest of your
recognizing
day.
that. Thank
Yes,
you.
thank you.